Where is that slide changer? So that is the, this is next, and this is we can't do.
This is for next, this is for back.
Okay. Thank you. Good morning, everyone. And first, I would like to thank Dr. Vitull, my friend, and organizing committee to invite me for this fantastic conference. So my topic of today is SGLT2 inhibitors in heart failure. So I'm not going to talk about what are SGLT2 inhibitors and their mechanism of action. So I'm going straight. Heart failure is a major public health problem. It's associated with significant healthcare cost worldwide. More than 64 million people suffer from heart failure, and you imagine the cost, 346.2 billion. Majority of the cost they are linked to the inpatient care and hospitalizations, specifically rehospitalizations. So there's a shift in the presentation of different types of heart failure. The global burden is increasing across the ejection fraction spectrum, while the prevalence of heart failure, reduced ejection fraction HFrEF is remaining stable or declining, but heart failure with the preserved ejection fraction prevalence relative to the HFrEF is increasing at a rate of 1% per year. So HFpEF is likely to become the most common type of heart failure. Heart failure poses two major challenges which greatly affect patient lives. Heart failure is the leading cause of hospitalization in US and Europe, and there 8 days is the median length of stay after hospitalization, and frequent rehospitalization they are accelerated path to mortality for patients. So 30% of patients they reported low physical activity, 59% difficulty with one or more daily activities, and 63% of patients age more than 60 they report symptoms that are consistent with depression. So it's a growing public health problem with high morbidity and the mortality. You imagine the burden, and it's a number one cause of hospitalization patient more than 65, and you imagine 5-year mortality rate for patient with heart failure is 50%. And mortality significantly increases after each heart failure readmissions. And this is when we called heart failure reduced ejection fraction less than 40%. Mid-range or mildly reduced ejection fraction is a 41 to 49% ejection fraction, and preserved ejection fraction when it is more than 50%, with some objective evidence of cardiac structure and of functional abnormalities consistent with presence of LV diastolic dysfunction. So changes in LVF occur over time, and they are associated with specific patient characteristics. Like heart failure, HFrEF can go back to HFMRF, can go back to HF preserved ejection fraction, and the same way it may deteriorate from HFpEF to HFrEF. Mortality risk remain urgent and life-threatening for heart failure patients. You can imagine here, in-hospital mortality is high after acute decompensation. 1 in 5 patients will be re-hospitalized within 30 days of a hospitalization admission, and poor outcomes driven by the frequent non-CV deaths, particularly in the heart failure preserved ejection fraction. You imagine the 5-year mortality is around 50 to 75%. So each hospitalization will bring the patient to closer to the death. Why these slides are so important to understand that it's a very serious problem to understand. Very early diagnosis of heart failure is very important to diagnose and start as early as possible GTMT treatment in any heart failure case. So, what are the goals of pharmacotherapy for patients with heart failure? That is, we want to reduce in mortality, the prevention of recurrent hospitalizations due to worsening heart failure, and improvement in clinical status, functional capacity, and quality of life. So there is urgent need to optimize evidence-based prescribing at every possible opportunity. And you can imagine if you see this big grid on the right hand side, only 1 in 5 heart failure reduced ejection fraction they are treated with the GDMT. What is GDMT? Is guideline directed medical therapy, and the number of HFpEF patients receiving GDMT is even very lower. And you see we are having a drug like SGLT2, ACE or ARB, MRA, beta blocker, then only you can imagine HFrEF case with diabetes or no diabetes, and then down is HFpEF cases with diabetes and the no diabetes. Why this bar diagram is showing that how many percentage of the people they are receiving this respective drug. Improving outcomes and quality of life of patients with heart failure, they are fundamental treatment goals. We want to improve functional status, improve symptoms, decrease mortality, and decrease hospital readmissions. We are having a two large multi-center international randomized placebo-controlled clinical trials. They provide evidence that dapagliflozin is one of the SGLT2 inhibitor is effective across the range of ejection fraction. So we are talking two trials. On the one side is DAPA-HF, left hand side, right side is delivered trial. We are talking about these two trials sideways. DAPA-HF 4,744 patients, and in DAPA-HF we had patients who had ejection fraction less than 40%. In delivered trial we had ejection fraction more than 40%. So and their elevated anti-pro-BNP and definite EGFR was more than 30 in DAPA-HF trial, and here DAPA declared delivered trial it was EGFR more than 25. So it was 1:1 randomization. So this is a pivotal study assessing DAPA-HF in HFrEF, and this is delivery's largest and broadest trial to date in patients with ejection fraction more than 40%. So this is then it was a final that prescribed Foxiga is a brand name of dapagliflozin to significantly reduce your patient risk of CV death or the worsening heart failure. You imagine in DAPA-HF trial 26% relative risk reduction of these primary events like CV death or worsening heart failure. And what is happening in delivered trial 18% relative risk reduction of this CV death or worsening heart failure. And this number is not small to understand. This is a very big number and very fantastic number. And there's another one questionnaire was there which is self-administered instrument for patients with heart failure that quantifies a broad range of health status domains. The questionnaire measures patient perception of heart failure impact across 6 domains like physical function, symptoms, symptom stability, social limitations, quality of life, and self-efficacy. After in this study, this KCCQ questionnaire was important. And you can provide your heart failure patient with rapid and sustained symptom improvement by prescribing dapagliflozin. So DAPA significantly improves symptoms as measured by these KCCQ across all clinical significant domains like physical limitations, quality of life, and social function. DAPA-HF trial shows benefits were seen as early as month 4 and sustained at the 8 months. You see, the drug is so effective that you are finding so many good effects very early. And delivered trial, they show benefits as early as 1 month and sustained at the 8 months. They're not a simple thing. I mean, some drug you're prescribing in any heart failure and you're finding so many good results. There was no attenuation in the benefits or DAPA on symptomatic improvement in those with LVF more than 60%. So only DAPA consistently reduces the risk of hospitalization for heart failure or CV death for your patient across the range of ejection fraction, whether the patient is of HFrEF, HFMRF, or HFpEF. All ranges of ejection fraction, dapagliflozin is really fantastic molecule as SGLT2 inhibitor, and there is no evidence of attenuation regardless of the LVF. There were previous trials, they have shown attenuation of effect at higher EFs like empagliflozin. Digitalis was not good found, ARB, ARNI, or MRA. All these drugs they have shown attenuation of effect at higher ejection fraction. They were found in this some of the drugs in the HFrEF reduced ejection fraction. So dapagliflozin significantly reduces your patient risk of CV death across the ejection fraction range, 14% relative risk reduction. That's not a small number what we find with these SGLT2 inhibitors. Rather in the last few years, in the last 15 to 20 years, SGLT2 inhibitor is the only fantastic drug which have shown such a benefit on the cardiovascular mortality. So no benefit in CV that and with AMPA. If we talk about other SGLT2 inhibitor, we are having three like DAPA, AMPA, and canagliflozin. So we are not talking canagliflozin as far as heart failure is concerned. That's very renal safe drug. But what about the empagliflozin? And many times this question arises: DAPA versus AMPA. AMPA, it has not shown any benefit in CV that even in the pooled analysis. So DAPA is the first and only SGLT2 inhibitor with mortality benefit in patients with CKD with and without type 2 diabetes. You imagine these trials, they had even non-diabetic population. So here was a question many times they asked me, I mean Dr. Kapoor, if DAPA is given to some non-diabetic person, is there any danger of hypoglycemia? I say zero. There is no danger. You can prescribe very easily to non-diabetic population because these trials they are non-diabetic population. So in CKD with or without type 2 diabetes, you can imagine 31% relative risk reduction of all-cause mortality with this dapagliflozin. So European Society of Cardiology recommends now SGLT2 inhibitor as a first-line therapy for patients across all EFs to reduce the risk of hospitalization, heart failure, or CV death. You imagine HFrEF, HFpEF, or HFMRF, sorry. So DAPA and AMPA, they have level of evidence is 1A, 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 and that is a really fantastic. That's now after so many years we have a drug which is a fantastic as far as the non-diabetic population you are going to write down with much of the benefits in all ejection fraction. We don't have any drug for heart failure preserved ejection fraction in for the last so many years. Now we are having, we can say we have a drug which we can prescribe in heart failure in preserved ejection fraction. SGLT2 inhibitors, they are a core therapy for heart failure reduced ejection fraction, should be initiated as early as possible as a pillar of comprehensive guideline directed medical therapy. This is 2024 ACC expert consensus pathway decision. SGLT2 plus ARNI plus MRA plus beta blocker evidence base. This is GDMT, four drugs. They are the pillars of HFrEF, and you can imagine. But there is algorithm to show like somebody is not okay with the volume overload. You can add loop diuretics. Then somebody is not resistant heart failure. You can add hydralazine or isosorbide dinitrate combination as solazine. And when the heart rate is not less than 70, the patient is in sinus rhythm, you can use ivabradine. And when the patient is on very resistant heart failure, you can add Versequat. All these drugs, they are available. We are using it. The latest is Versequat. It's a fantastic molecule. We are adding to our resistant heart failure reduced ejection fraction cases. And what about in preserved ejection fraction? Talk about SGLT2 is a really drug. In a reduced ejection fraction, we have four drugs. But in preserved ejection fraction, the only drug is SGLT2 inhibitors. And you can add loop diuretics if there is a volume overload. And for the woman, all ejection fraction, you can add MRA. And for women, men with the LVF, and add ARNI. And for ARNI eligible who cannot take due to cost, you can add ARB. This is a very important algorithm to understand in the HFF case. So the time to rethink heart failure management is now. Groundbreaking heart failure guidelines reflect how DAPA can protect your patients across all EFs. And with the GDMT, you can reduce your patient risk of CV death across the EF range, give your patient symptom improvement and improved quality of life, reduce your patient risk of hospitalizations. So heart failure guidelines, they are for the first line treatment in the HFrEF reduced ejection fraction. Start for GDMT. Then there is again you can add diuretics or MRA as indicated. So what are the opportunities to significantly reduce the burden? DAPA is indicated in adults for the treatment of symptomatic chronic heart failure. It offers simple dosing, 10 milligram OD, and these are the DAPA has well studied safety profile. We don't find any much of the adverse events. They revolutionize heart failure management in your practice. Prescribe DAPA to all eligible patients. Drive the change by encouraging GDMT adherence and supporting multidisciplinary working to help optimize care for heart failure patients. Provide guidance to multidisciplinary teams such as those with nephrology, endo, and primary care to consider introducing DAPA in symptomatic heart failure patients across the range of ejection fractions, and now study in patients with all ranges of ejection fraction DAPA is proven to reduce hospitalization episodes, proven to improve symptoms that limit their lifestyle, and only SGLT2 with clinical evidence from multiple studies that it reduces the risk of death for patients with heart failure or the CKD must be my last slide. Thank you very much. Yes.
Thank you, Dr. Rohit. This is real important to discuss SGLT2 because SGLT2, as it was introduced, now the therapeutic horizon is widening for SGLT2 and supposedly being given in almost each and every condition regarding metabolic diseases.
Yeah,
So thank you
definitely.
very much.
Thank you very
For
much.
the audience information, Dr. Rohit Kapoor is a celebrated, speaker, famous practitioner from Amritsar. Thank you very much for
you very
taking
much.
out time to attend MAPICON out of your busy schedule. We are really appreciating your presence
Thank you.
and acknowledging your endeavor to promote MAPICON. Thank you
much.
very much.
Thank you
If
very
there are
much,
any
Dr. Vitull.
questions,
All right. Thank you.
so
Thank you, Dr. Vitull.
Thank you very much.
Thank you for your insight.